You mentioned the high NPS scores. Do you have any statistics on outcomes from a quality or cost perspective?
We measure clinical outcomes on every patient that comes through the door. Around 93% of our members achieve significant symptom improvement or resolution within 3 to 4 months. And that's often having had their symptoms for 2+ years in many cases. On the cost saving side of things, we've been able to show around a $2,400 cost savings per patient in the first year. And this was done through a case match control claims analysis in partnership with one of our plan partners.
Welcome to the next episode of Scale Communities Technology and Innovation in Healthcare podcast. I'm joined today by CEO and founder of Visana Health, Joe Connolly. Joe, welcome to the podcast.
Thank you for having me.
So maybe for those that aren't familiar, let's begin with just a quick overview of Visana and what you're looking to accomplish in the healthcare market.
Yeah, I always love to start with my why on why I founded Visana. So it was formed from my mom and grandma's experience with complex gynecological conditions like endometriosis and uterine fibroids. My mom would have pain so bad during her period, she would be vomiting 3, 4 days every single month. Could not get out of bed. And despite that, when she saw dozens and dozens of OBGYNs and primary care providers over the course of 25 years, she was really dismissed and kind of given a pat on the head and told that she should take some ibuprofen because painful periods are a normal part of being a woman. She finally found her way to a doctor who told her that she needed a hysterectomy, and that was the first and only treatment that was ever offered to her. So she skipped all evidence-based and conservative therapy. And so our core belief at Visana is that women's health is so much more than fertility and maternity. And don't get me wrong, those are critically important categories. But 90% of women are not building a family at any given time. And women's health is so much more expansive than those categories. There are conditions that uniquely impact women, like the conditions that impacted my mom and aunt. There are conditions that disproportionately impact women, like thyroid, which is around 80% women, autoimmune, which is around 80% women. And then there's conditions that differently impact women, things like cardiovascular disease. And so Visana has really built a comprehensive virtual women's health clinic to take on those conditions. And we go beyond just fertility and maternity to provide whole person medical care for 100% of women across all life stages. So we have an in-house 50-state medical group that allows us to diagnose, triage, and treat all women's health conditions from menstruation to menopause. And really what we specialize in are the most costly and complex conditions like menopause, endometriosis, polycystic ovary syndrome.
So given that it's a fairly expansive scope, whole health for women, 50% of the population, give us a flavor for, and you're covering 50 states, give us a flavor for the provider scope. Are these primary care providers? Do you have a cohort of specialists? How many providers? Are they full-time?
Yeah, so we prefer our providers to be W-2 because we found that we are practicing medicine in a very different way than the way that providers are used to practicing medicine. A lot of providers that I talk to sometimes feel like they're cogs in a wheel because they're on the fee-for-service hamster wheel and they have to crank out short 6-10 minute visits that don't allow them to provide that more expansive scope of services. And if you think about OBGYN as a specialty, it's a very broad scope of service. We're expecting them to be primary care providers for women. We're expecting them to be obstetricians, and we're expecting them to be gynecologic surgeons. And so at the end of the day, it can be really difficult to provide that more primary care element. And so what we've assembled is a group of both OBGYNs, primary care providers, women's health nurse practitioners, nurse midwives, and even most recently, we have a full-time endocrinologist on staff because we found that there's a very intimate link between women's health conditions, hormones, and these endocrinology conditions because polycystic ovary syndrome directly leads to diabetes. And so we've really assembled all different specialties that allow us to be the medical home for women. And what we typically see is there's a few different flavors of women that are coming to us. Menopause and midlife is a really big topic right now. Women are really raising their voices and realizing that they're not receiving the most optimal care from brick and mortar providers today. So we see a significant portion of those. We are seeing many women that have polycystic ovary syndrome, metabolic conditions, and they are looking to get pregnant. They might not be menstruating, and they are asking us to help them achieve pregnancy. And then we also see a number of women that have complex gynecological conditions like endometriosis and fibroids. Those are some of the core women that are coming to us. We found that around half of our women don't have an OBGYN or primary care provider. So we have really built that comprehensive medical model to be able to support the women that are coming to us today and constantly figuring out how we can continue to close various gaps in care for the patient population that is seeing us. We are seeing women that have 4.3 different comorbidities. So they don't just have menopause, they have all the different cardiometabolic conditions that come to life in that phase of life. And because half of them don't have a primary care provider, they often aren't receiving care for those different conditions. And so we have really purpose built the medical model to treat that high acuity population.
How many patients are you seeing today?
We're seeing around 200 patients a day. So we're operating at a pretty sophisticated scale. We've seen over 30,000 patients across all 50 states, predominantly through in-network relationships with health plans. So we really seek to make our care affordable to patients. And we disproportionately see rural patients, as I'm sure you can imagine, that they don't really have the access to care that you might expect. But we're also seeing a surprising number of urban patients, because what we're finding is if you don't have a relationship with a primary care provider or an OBGYN, let's say you move states, for instance, it can take 6, 9, 12 months to get that initial visit because there's simply not the capacity to be able to meet all of the demand in the system today.
Patients finding Visana Health. I mean, I can tell you from my experience with telehealth, it's been episodic. So there are, maybe something pops up, like I'm traveling and I have a question about travel health, and I'll do a telehealth visit. I know a lot of people were exposed to telehealth during COVID, but then maybe pulled back and went back to the office after COVID. So all these patients who they don't have a primary care provider to begin with, you're serving underserved populations. It sounds like, whether it's rural or otherwise underserved. How are they thinking to come to Visana in the first place?
Yeah, there are a number of ways that we are able to reach patients. We partner deeply with both health plans and employers to be able to raise awareness about the services that we provide. So for a little bit of an example, we will partner closely with school districts to help raise awareness for their teachers that they're able to get appointments during their lunch break or before or after school, so they don't have to get a substitute teacher in order to receive care for themselves. We partner with health plans to be able to raise awareness of our services through emails and direct mails to their fully insured populations as well as their self-funded populations. And then we host webinars for members to learn more about these conditions, because unfortunately, women's health is often under-researched, and there's misinformation out there today that we need to help correct to be able to build trust in that audience, to make sure that they understand that they can come to us with their needs and we will hear them and be able to help solve their issues.
So it sounds like more of a B2B2C model than directly B2C or direct to patient model. Is that a fair?
That's 100% correct. And increasingly, we're seeing more and more friends and family referrals of patients that came to Visana, had such a great experience, and they're telling their wives, their mothers, their daughters about it.
So let's talk about, still keeping on this theme of the patient acquisition journey, and then we'll get to the patient experience journey in a second. But on acquisition, so you sign up a school district, you collaborate with a payer. I imagine that's not the end of the story. You still have to convince the patients to sign up with Visana rather than work with another provider or status quo. How does that experience work? What role does Visana play? We deal with a lot of companies that are approaching the employer market, and I know this concept of what's called steerage is critical and is complicated. And so it sounds like you've built maybe a skill set or a muscle in the art of steerage. So I'm just wondering how that works.
Yeah, definitely. I think that steerage that you just mentioned can often be the Achilles heel of digital health or virtual care solutions. It can be very difficult to be able to get patients to ultimately enroll and utilize your services. And because so many of these business models are increasingly moving towards utilization-based payments. So for example, Visana, we submit claims for our services and everything runs through the medical expense. We typically don't charge a PMPM for any of our clients. And that's increasingly the way that healthcare is getting paid for today. I joke that employers are allergic to PMPMs now, particularly in an era of point solution fatigue. And so we have really focused very heavily on being able to build those relationships with patients ahead of their initial appointment, build that trust, because we found that trust is really critical for these, and then ultimately help nurture them throughout their journey, their early journey in Visana, to get them to that initial appointment. A few interesting things that we found is we operate in the women's health space, and a lot of times women, when they go to the OBGYN, assume that they need a pelvic exam as part of their course of treatment. And so a significant portion of our educational material helps women understand why they might not need a pelvic exam for the conditions that we specifically treat. And this is directly in accordance with ACOG, the American College of OBGYN's guidance as well, that does not require a pelvic exam in the majority of clinical cases. And so there's different barriers that we have to be able to help women overcome, that we've done a lot of patient interviews to figure out why patients might not engage. And you can see that type of language on our website today. Another thing we have to do is really partner closely with that employer and the health plan to understand their population, understand the existing communication channels that they have today, and then figure out how we can deploy those communication channels in a way that's really scalable. One of the things that we found to be critically important is a lot of the women that we serve have often been dismissed by the healthcare system. They've been told that their symptoms are all in their head, that they've exaggerated their symptoms, or maybe that they're not candidates for hormone replacement therapy. And so we found it's really critical for us to be able to get our providers out there to be able to talk about the services that Visana is able to provide so that we can start to rebuild that trust with women, and they can see that, again, we are practicing medicine differently. We have a 45-minute initial visit. Women get all of their concerns addressed, and I think that's evidenced by our NPS of 91. And then the last thing that I would say there is women are really, they need better access to care. Oftentimes, some of these conditions, if you think about a UTI or a birth control refill, might be urgent. They might need to be seen same day, and oftentimes they might be lacking that access with their standard brick and mortar OBGYN. And again, there was recently some data that showed that it can take up to 4 weeks just for a new patient visit across the nation. In some cases, that's 2-3 months. In Visana, we often provide access within 2 to 3 days. And so that differentiated level of access also allows women to get seen earlier, and that can really help drive that enrollment and utilization as well.
Where are we today in terms of regulations? Can providers see across state lines, or are there limitations that you face in that?
Yeah, so providers are able to practice in the states that they're licensed in. And every state kind of has different licensing situations. And so some of them are more difficult than others. We also have a predominantly nurse practitioner-led workforce, and there are also state-by-state regulations for nurse practitioner oversight laws. And so we have to have this very complicated and entangled web of not only licensing, but also nurse practitioner oversight and collaborating agreements that often have to get approved by the state medical boards before our practitioners can start practicing. And then you also layer on the health plan credentialing side of things, which often is also state-by-state. And you can imagine how that becomes very complicated very quickly to be able to scale that out nationwide. And it's a core competency that we've been able to build inside of us.
I was going to ask, so net, are you expanding your supply by being virtual, or do these regulations really make it difficult to expand your supply because you have to be state centric?
So we invest very heavily in our providers in Visana. Many of them are W-2. We really seek to build a longitudinal relationship with patients because they end up building trust with their individual provider, and they want to see that same provider consistently over time. You'll hear that theme of trust time and time again. So because of that, we are able to really cross-license a lot of our practitioners. So many of them have 20, 30, 40, sometimes 50 state licenses. And then there's a whole geographical strategy where we can help get providers licensed across the more difficult states, as well as keeping them in some of the more high volume states that can help fill up their schedule. And so the supply and demand forecasting is a really critical component to being able to be a successful virtual care delivery company, because you're managing this complexity on the supply side. And then you also have to have pretty mature forecasting of demand on the demand side, which obviously includes, if we do a webinar with an employer that's predominantly based in Colorado on a Wednesday, we now have to figure out how can we increase our supply of providers on Wednesday in Colorado so that they can meet that patient demand. And so that level of calibration is very difficult, but very critical to being successful, because on one hand, if you're understaffed, then you're not able to capture the demand that's at your door. And if you're overstaffed, you're spending additional capital unnecessarily because providers are not fully utilized.
What I'm trying to build up to is really get to the question of how good is virtual health? How incrementally valuable is it? So on the topic of access, it sounds like you can serve rural markets, underserved populations. And so that's, check. That's on the positive side of the ledger for virtual care. It also sounds like you can solve for geographic specific supply demand imbalances by opening up broader supply that's partially constrained but not as constrained, because you can pull from different states, different parts of the country. So you've solved for supply. The steerage and education, I think arguably you can do that if you were an in-person business too, educating patients on, do they or do they not need a pelvic exam, for example. So I'm not sure that's unique as unique to virtual care. But what about when it comes to quality of care? You mentioned access, getting appointments within 2 days instead of 2 weeks, or whatever the case may be. So that speaks to quality. What about quality and cost of care? Are there unique benefits that come with virtual care relative to an in-person model?
Yeah, I think one of the fundamental issues with the in person model today is that many of them don't have the appropriate clinical supply to really treat the conditions that we treat, nor do they have the payment model set up to be able to effectively make money and be margin positive on some of these conditions. And just to give you a few examples, we've had a number of conversations with health systems over the course of the last few months and years where they've told us that they are so capacity constrained on the OBGYN side that they can't provide care for menopause patients. In some cases, they're not doing well woman visits. They really struggle to see heavy and irregular periods because they're dealing with high risk pregnancies. They're dealing with women that have such severe heavy menstrual bleeding that they have extremely low and dangerous hemoglobin levels. So, just from a triage perspective, they have to focus on what they would consider high acuity patients. And that's often to the detriment of the quality of care, where it's really difficult to even access basic services if you don't have that very, very severe condition that needs to be treated in person. And so oftentimes that means those conditions are left to a quick 6-minute visit where women aren't necessarily feeling like they're heard and they feel like their issues aren't being solved in a specific visit. So like I mentioned, we do 45-minute visits and we're asking women just not just about their gynecological issues, but also their cardiometabolic health, their digestive health, their urinary health, their behavioral health issues, and putting together all of the different pieces to be able to create a comprehensive and cohesive care plan that can really get to the root cause condition of whatever is driving their symptoms and treat that underlying issue, whether it's a thyroid condition, a gynecological issue, diabetes, or otherwise, and be able to drive to much quicker results. So just a few numbers. I mentioned that we have an NPS of 91 earlier. So women just love this care experience. And we routinely get comments on our NPS surveys that say, I feel like I've never been heard before. I just saw 5 brick and mortar providers and they weren't able to put the pieces of my health together. And I think that's more, it's at no fault of the brick and mortar providers because the system just isn't set up in a way for them to succeed in some of these conditions. Most of
So
our
it's,
patients.
again, it's a supply demand question is what I think you're the root of what you're saying, that the in-person clinic can't see patients for 45 minutes because they just don't have the provider supply economies of scale, given that they're confined by a local clinic geography. Is that ultimately correct, or?
That's certainly a point of it. And then I also think that there's just the financial incentive there where, an E&M visit might pay $200 in a brick and mortar setting and, 45 minutes of an OBGYN time plus just the overhead of a brick and mortar clinic. It's really, really difficult to be able to make any money doing those types of services. OBGYNs typically can make a lot more doing gynecologic surgeries like most surgical specialists can, or by delivering babies. And so it's also rethinking the financial structure of the organization to be able to provide that level of care and also having the payment model in place with health plans to be able to provide that level of care and ultimately get paid more for outcomes.
But you face those same limitations too. I think the in-person clinic could easily hire nurse practitioners, PAs, but I think ultimately so yes, you save on rent, but they could hire the APP mid-level team. They might face challenges doing that because I think their patient pool is just whatever is limited to that one physical clinic. So I think it sounds like by opening up virtually, able to be creative when it comes to meeting demand with supply from different parts of the country. You're subject, I imagine, to the same E&M reimbursements that the in-person clinics would have.
Yes, we are, but we typically contract with health plans and self-funded employers in more value-forward arrangements. So we have pay-for-performance arrangements where we are paid when we achieve a certain outcome. We have total cost of care arrangements where we have upside-only shared savings arrangements where we can share in the cost savings that we're able to produce. So there's other payment mechanisms above and beyond just the E&M coding that allows us to get paid for the higher quality care that we are delivering, which is not necessarily typical in a brick and mortar environment where if people are thinking about value-based OBGYN reimbursements, everybody goes to the OB bundle and a maternity case rate is typically what you see. And there's far less innovation payment innovation on the gynecology side of things.
And are patients typically coming to Visana first before they go see an OBGYN or another specialist, or are you partnering with the specialists to provide supplemental coverage for that practice?
It's around 50-50. So around 50% of our patients have had or are in active care of an OBGYN and primary care provider. And for instance, Primary care providers aren't necessarily well educated around menopause and hormone replacement therapy and who is a candidate or not. So they may be coming to us for that specific issue. And then half of our members don't have OBGYN or primary care provider. And that's where we can really step in and provide that more comprehensive care.
So how does it work, Visana being the virtual arm, how does it work with the in-person clinics? Because obviously there are cases where you do need an in-person provider. Certainly if you had a procedure, you would need an in-person facility. How are you building out your referral network? And what's that relationship like, where the relationship is partly additive, but partly competitive with some of these specialists?
Yeah, I think regarding the competition, I think alluded to the fact earlier that many OBGYNs don't necessarily want to be providing the services that Visana provides today. They want to be operating at the top of their license. And if you're a minimally invasive gynecologic surgery, you've done additional fellowship training to be a surgical specialist. And they want to have patients referred to them that are surgical candidates at the end of the day. And so there's a really nice symbiotic relationship between us and brick and mortar providers because they are often so capacity constrained that they want to work closely with us so that they can offload some of what they would consider lower acuity volume to practitioners like Visana that can manage it much more effectively and efficiently in a virtual site of service. And then we can refer in for whether it's labs, imaging, that includes mammograms, ultrasounds, or procedures. All of those things are needed. Just as an example, we often see women that are perimenopausal or postmenopausal, and they can have postmenopausal bleeding. And that needs an additional in-person workup. And we fully coordinate that care with a brick and mortar OBGYN. In this case, postmenopausal bleeding can often be an early sign of cancer. So we need to make sure that we don't just get that patient referred in, but we fully coordinate that care. And what that means is our care coordinators get on the phone and make sure that they're able to be navigated to one of our in-person partner clinics. And we actually help call. So we are physically calling the practice and making sure that they have availability in a reasonable amount of time for that specific patient. And that level of personal connection allows us to often get these patients that need to be seen urgently, seen even faster, and really help expedite any time to diagnosis or time to procedure that might be required. So we do a lot of vetting for those in-person providers because like I mentioned, many of these OBGYNs have a very broad scope of service. Some of them are more surgical specialists. Some of them are more specialized in OB. So we need to make sure that we're referring the patient ultimately to the right provider.
You mentioned the high NPS scores. Do you have any statistics on outcomes from a quality or cost perspective?
Yeah, so we measure clinical outcomes on every patient that comes through the door. And many of these gynecological issues at the end of the day are symptom based. So what we need to be able to measure is symptom resolution. Around 93% of our members achieve significant symptom improvement or resolution within 3 to 4 months. And that's often having had their symptoms for 2+ years in many cases. On the cost saving side of things, we've been able to show around a $2,400 cost savings per patient in the first year. And this was done through a case match control claims analysis in partnership with one of our plan partners.
So it sounds like a lot of positives here, right? Again, opening up access, improvement in outcomes, lowering of costs, specialists that get to practice at the top of their licensure. Where are you facing resistance? I would imagine the payers are happy. Where are you facing resistance?
At the end of the day, there's still an activation energy that requires to get Visana set up with many of these services. And many health plans and employers, I mean, they're looking at solutions not just in women's health, but across all different condition categories. And so there's a lot of education that we have to do to help explain the importance of these problems, because what we found is that these are actually very high cost conditions, but the condition buckets are often in different verticals. So for example, fibroids, which is a benign tumor in the uterus, is classified as cancer when they look at their claims data. And so there's a level of education that we have to do to help them understand why this is such a big issue, because many people still think women's health is synonymous with maternity. And so that level of education is something that we have to do with the self-funded employers and health plans to be able to help them understand why this is so important to invest in. Because like I mentioned, we are often taking different payment arrangements that require administrative cost and time from the health plan to be able to set up. The other thing that I would say is there's still some skepticism around the quality of virtual care amongst brick and mortar providers. And oftentimes we have to help educate them around why we can or cannot do something virtually. Just to give you an example, we have patients that come to us with breast lumps. That might be something that you might say, hey, how are you going to manage a breast lump virtually? We can actually do quite a bit for it with our care coordination. So we can order mammograms, we can pull the past medical records and make sure that the radiologist on staff is able to compare the past mammogram to the current mammogram. And if there is cancer, we can help coordinate any downstream care that might be needed. But we have had radiologists call us and say this isn't necessarily appropriate for you guys to be managing virtually, but we're really able through that access that I mentioned to really shorten that time to diagnosis and get them seen by the appropriate in-person provider and help be advocates for our patients at the end of our day. And we believe there's a lot of value in being able to do that. But I still think there's this longstanding belief that virtual care equals urgent care, right? And we are really building this more longitudinal solution that's more integrated with brick and mortar care, and helping people understand that can sometimes be a barrier.
You chose to go broad, 50 states. Are there differences in how advanced your model is by state? So for example, one state you've got deep partnerships with the right complement of in-person specialists, but another state you're just virtual and you haven't yet built out that complement of specialists, or is it pretty universal across all 50 states?
It's pretty universal across all 50 states, but we do see differences in our patient population and the needs. For example, we diagnosed a patient with cancer in Montana, and we needed to coordinate her downstream cancer care. We had to do a lot more work to find that downstream cancer care that was a reasonable drive away from her, that had a specialty in the type of cancer that she had. So for that, sometimes we have to go above and beyond to be able to really build out those relationships. So there's certainly variability that we encounter, and we have to work to be able to meet our patients where they are and be able to solve their issues.
So let's imagine a large national women's healthcare business that has, hundreds of providers, thousands of providers, lots of clinics across the country. Should they be working with Visana to handle the telehealth portion of their business, or would they be just as good building a telehealth portion of their business in-house?
Yeah, I think ultimately we believe that partnering with Visana would be the way to do that, because we've gone through the hard work of setting up this 50-state medical group. There's a large technology lift to be able to invest in. And so certainly if the brick and mortar company had the resources to be able to build a layer on top of it, I think there would be tremendous value for them, because they'd be able to provide that differentiated access. It's just a matter of whether they're able to have enough capital to be able to invest, or whether a partnership would just make more sense at the end of the day, because the value for them is really helping triage patients and get them into the appropriate side of care, which they would often say, getting those higher acuity patients to them is the ultimate value for that layer.
Shift gears and sort of look forward from a macro perspective. So we speak to a lot of technology companies and sort of ask about where the market's going, and you hear broad sort of spectrum. Some people think that 80% of the provider market is going to be replaced by technology over the next 5 to 10 years, and others take a more conservative or skeptical view of that. So I want to ask the same question about where the market not necessarily is going, but where you think it should go in terms of utilization of telehealth. If you were to reinvent the healthcare landscape, what role would virtual care play in the market? What percentage of care would be delivered virtually versus in clinic? How would virtual care partners collaborate with the in-person clinic, with hospitals? What would the reimagined healthcare landscape look like?
Yeah, I definitely think that virtual care would often be the front line of care for many different patients. The key here is that it has to be tech enabled. So we have a finite capacity of clinicians here in the United States. And in order to be able to meet the projected demand, which is only going to increase, and we already have access issues, technology is the solution that can really get us there. It not only meets patients where they are, but it can make the clinicians more efficient and hopefully be able to drive eventually arbitrages in that supply demand landscape. Now, I think core to this is the current fee-for-service payment system that we live in today, where you get paid for a face-to-face visit, incentivizes providing different levels of access at the end of the day. So until we can really uncouple ourselves from that fee-for-service systems where there's E&M visits, we can't do asynchronous care as effectively. And some of the conditions that we treat at Visana could definitely be treated asynchronously. And so we have to not only rethink the technology landscape and the clinical landscape, but we also have to think about the payment models at the same time, because those two things go hand in hand. And ultimately, in working with lots of different payers, many of them are constrained by their own technology ecosystems, where it's just simpler and easier to administer fee-for-service payments that run on current CPT codes and run on their current technology chassis than trying to do something different. So I think there's going to have to be an evolution of the healthcare system writ large to be able to achieve this ultimate goal. But I think it's an area that we need to go to because patients deserve better access and they deserve better care than what we're able to deliver today.
And I guess with virtual care, you open up the opportunity to potentially expand the provider supply pool even globally beyond the geographic bounds. So is that something that you see our market shifting to in order to address sort of the supply shortages, or is that difficult to do for other reasons, for regulatory reasons?
Yeah, I think we talked about the licensure issues not too long ago, and that kind of is, and the credentialing issues. And I think those two things are really at the crux to being able to open up the supply more broadly, where you would have to get a licensed clinician that is credentialed by the health plan and passes all of those checkboxes. But I think it's something that the healthcare system needs to continue to consider because we're going to continue to be more and more capacity constrained at the end of the day, and technology will only get us so far. And I think we're going to have to think about different supply pools that we're able to tap into. And some people are looking at APPs, as we've discussed. I think global is another area where we could consider how we can continue to increase the supply locally by working with clinicians that aren't within the 50 states that we operate in today.
Serving underserved populations is a big topic and an important one. Could Visana be doing more in those markets? And what would you ask for from the healthcare market to allow you to do that?
Yeah, definitely. Particularly in women's health, a lot of women of color suffer disproportionately from some of the conditions that I've discussed and certainly have very well documented outcomes. And we talk about rural patients, they also have a lot worse outcomes than more urban patients that have more ready access to care. And so I think there's always more that we could be doing at the end of the day. And I think a lot of this, like I mentioned before, comes down to trust within those populations and helping us build the trust with those groups that are underserved so that we are able to help them get into the healthcare system and start to participate a little bit more. And so I think the more that we keep that at the forefront of everyone's minds, I think the better. We have tried very hard at Visana to be able to create a clinician workforce that looks like the population that we serve. So 40% of our providers are women of color and around 20% of them are LGBTQ plus specialists. And so we've really been thoughtful around the way that we've constructed our clinician base to be able to try to reach those underserved populations and make sure that there's empathy with the end user at the end of the day.
You mentioned about the high NPS scores for the patients. How about the providers? How do they compare the experience working virtually versus in clinic?
Providers love working at Visana specifically. And I think part of this is because we're practicing medicine in a different way, like I mentioned before. So we are specifically looking for providers that want to provide whole person care, right? So we don't believe that women are chopped off at the head, and we need to not just think about their uterus, but all of their other issues that might be going on as well. And there are many people that subscribe to that type of medicine, and they believe it's the right type of medicine. And those are the types of people that we recruit for at Visana so that we can really provide that level of care. So many of them often feel like they're doing a disservice to patients because they only get 6 minutes, 10 minutes with the patient. They say, gosh, if I had more time and more support, then I'd be able to do a much better job. We also think very deeply about how we support our clinicians with continuing education. So we have a very vibrant clinician community because many of them are W2. They work and collaborate closely. They share notes. We have escalation protocols when necessary. We've got support from OBGYNs, primary care providers, endocrinologists that can help collaborate on care plans, discuss difficult cases. And we create an area where they're able to really learn and grow as an individual and become a better provider. And so that fundamental level of support, I think, is really critical to being able to foster a positive clinician culture.
Last question is looking forward at Visana. 3 to 5 years from now, is Visana doing something similar to what it's doing today, just with more patients? Do you continue to focus on the employers and payers for your referral streams? Are there additional services that you take on? What stays the same and what changes over the next couple of years?
Yeah, so I think I talked about some of the conditions that uniquely, differently, or disproportionately impact women. And I think you'll see Visana take on more and more of those conditions that differently or disproportionately impact women because we are routinely seeing the gaps in care in the work or the patient population that we serve today. Just to give you an example of that, we were routinely diagnosing women with HbA1cs of 11 or 12. They have very severe diabetes, and we couldn't get them in to see an endocrinologist for 6 months to a year. And so, because we saw that in our own patient cohort, we really felt like we needed to layer on endocrinologist in house. And so we did that. And so, as we're continuing to see these gaps within our patient population, we'll continue to add on additional services that can really meet their needs so that we can really be that medical home for women. Today, we predominantly serve the commercial and self-funded markets. And I have a passion for trying to improve the lives of women and trying to figure out how we can make a model like Visana work in the Medicaid space as well, because it's a predominantly female population that has a lot of different health needs. And it's a real opportunity to be able to improve the lives of many, many women who really lack access to care.
Actually, just maybe a question related to that. I'm thinking about a lot of visits might require lab work or some other type of diagnostics. Is that a point of friction that at that point the virtual visit becomes an in-person visit? Have you explored things like home care to try to solve for that? How does that work?
Yeah, so we currently have agreements with national labs so that we're able to provide that seamless brick and mortar connection. A large number of our patients do need lab work because they're overdue for their diabetes tests or their annual wellness type labs. And so we have really built that out across all 50 states to be able to provide that level of care. We would love to be able to provide an even better experience in terms of the home care that you just mentioned in home labs. The critical piece is being able to provide that affordability for our patients, where if they're able to go see a brick and mortar lab and they can get that reimbursed through insurance, they're likely to choose that over a home lab kit that is oftentimes not covered by insurance. And so we're always trying to advocate for what's right for our patients so that they continue to access services that can help close those gaps, where if they live a long way from a lab and the lab is really critical, then we can maybe offer them a home lab. And so I think we'll start to see that evolve over time, as well as some of the health plans really start to think about how to appropriately reimburse for these services.
Yeah, no, it's very interesting. I think just thinking about some of the specialty groups we deal with, and I'm wondering how many would be receptive to this, and you can easily see how Visana would be additive to these organizations. So I think it'll be interesting to watch. But Joe, I appreciate the time. And congratulations on what you built out. It's clearly doing a lot of positive things in the market. So kudos to you and the team for achieving what you've achieved so far. And thanks so much for the time. And I wish you lots of luck in building out what you hope to build out over the next couple of years.
Yep. Thank you for having me.